The All Eyes Visual VRP is a portable vision testing platform that includes visual fields, acuity, color vision testing, pupillometry, and extraocular motility. The visual leverages virtual reality, artificial intelligence, and augmented technologies to enable eye care providers to test for and monitor common eye diseases. Visit alleyes.com for more information. With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you. Do your patients know what presbyopia is?
There are people who are afraid of the press.
Have you talked to your patients about multifocal contact lenses?
I've heard the bifocal, but not multifocal.
Exactly, not multifocal.
Do you need help with your multifocal strategy? Learn more at the conclusion of this episode.
Your eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with MicroMicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and MicroMicelle technology.
Hello and welcome to the Open Your Eyes podcast. I'm Dr. Kerry Gelb, the host of the documentary Open Your Eyes. If you're new here and you like our interviews, press like, subscribe, share, and hit the bell to get notifications of great new interviews. Also, please leave comments. Great news, you can now watch our full-length documentary, Open Your Eyes, on Amazon Prime, Apple TV, iTunes, Google Play, and YouTube Movies and Shows. The visual field test was first performed by Hippocrates in 150 BC. The visual field test is used by eye doctors to detect numerous systemic, neurological, and eye disease states. Visual fields detects areas of visual loss. Examples include brain tumor, stroke, glaucoma, diabetes, macular degeneration, and head trauma. Today's guests, North Carolina optometrist Dr. James Fanelli and research neuro-ophthalmologist Dr. Alberto Gonzalez are here to explain how the once tedious visual field test has been transformed into an exciting and interesting test for patients to perform while providing valuable diagnostic medical information to the physician. Dr. Fanelli lectures around the globe on a variety of topics, including injection procedures and advanced diagnostics and therapeutics. Dr. Gonzalez has completed a glaucoma research fellowship at the Hamilton Glaucoma Center, University of California, San Diego. Dr. Gonzalez is currently the Chief Executive Officer of All Eyes. Gentlemen, thank you for joining me today.
Thanks, Kerry. Appreciate that.
Thank you, Kerry. Thank you very much for the opportunity.
I really love that the two of you are here, experts on a pretty complicated subject, understanding visual fields, because when you're in the clinic and you're examining patients as optometrists or as an ophthalmologist, and things are going routine for a while, and all of a sudden you have this visual field change on your screening visual field, it could be something that's very serious. Dr. Fanelli, can you kind of explain how you feel when you kind of get that kind of punch in the nose that, we have this very unusual visual field, and that means it could be something dangerous or unusual?
Well, that's a great point, and I would say I probably get punched in the nose just about every day with that, because there are a myriad of ophthalmic and neurologic conditions that are going to affect vision and the visual system. And the way to hone in on that problem is by, in many cases, doing a visual field along with the rest of the ophthalmic examinations that we perform. But visual fields are incredibly important in localizing exactly where, or within a reasonable degree of certainty, where the problem lies from a structural perspective. Is that in the retina itself? Is it in the eye? Is it in the optic nerve? Is it further back? Is it around the pituitary gland? Is it in the occipital pole in the back of the, in the back of the brain? And all of these conditions are problematic that can either threaten vision at a minimum and sometimes can be indicative of life-threatening conditions. And it's incumbent upon us, as we're seeing these patients, to be able to assess, is this something that's long-standing, slow progression, for example, like glaucoma, or is this something acute where this patient needs to leave the office now and go to the emergency room and maybe heading to neurosurgery this same day? So it runs a very, very wide range of conditions, from those that are a bit more safer, if you will, slower growing, slower progressing, to those that are life-threatening.
Dr. Gonzalez, you're a neuro-ophthalmologist, and a neuro-ophthalmologist is often the last stop. When none of the other doctors know what's going on with the patient, they send it to the neuro-ophthalmologist. Tell us about that.
Well, thank you very much. And it is funny what you say, because I have a professor of mine. He's a neuro-ophthalmologist, and he used to say, "Oh, we the neuro-ophthalmologists are the one that are allowed to say we don't know." But jokes apart, I think it's the visual field test as part of the psychophysics of vision are very, very important tests in the genital eye examination. I always use the example because there's a tendency, which is good, I'm not saying it's completely bad, but there's a tendency for rely more on objective tests. Of course, that makes sense because you have less variability. But if we use the example of the autorefractor, you remember autorefractor have been available probably since it's in the 70s or probably earlier. And we are still asking the patient, do you see better with you? Do you see better with this? And that's because vision is a very complex, and part of the complexity is the subjectivity of vision. So I believe visual fields are going to stay with us for long. And that's the reason why OI exists. In order to change the perception that patients are having about tests like visual field. They don't need to be cumbersome. They don't need to be tired. They can be fun. They can be kids. They can be games. And that's our goal. So visual field, I totally agree with Dr. Fanelli. It's a very, very important test that we should know very well, and do it more frequently than we do, actually.
So the visual field tests, patients, physicians, I remember the days of the Goldman visual field, tangent screen visual fields, and the visual field for the patients have always been very tedious. Patients complain about doing it, but Dr. Gonzalez, you were able to, I believe you're one of the developers of using virtual reality, using a headset to make the visual field almost a fun test. Can you talk a little bit about that and where the idea came to put it in a virtual reality test?
Right. Actually, the using virtual reality technology to accomplish, psychophysical tests like visual field are very old. We're talking, there is a patent from the 80s, actually, that was describing using this kind of technology. So it's not a new concept. We have been just lucky to live in a time where the virtual reality technology has evolved sufficient to be, number one, accessible, affordable, but also well developed, easy enough for us to be able to add all these kind of tests. Yes, we started about 4 or 5 years ago, developing the first version of virtual reality. We brought it to the Wills Eye Hospital, where we did the first validation, and we can show later on some of the results. And the first initial, pilot study was very good and encouraged us to continue the development until today. That is not only a visual field test, but a comprehensive platform for perform eye tests.
So are you a gamer? Are you a secret gamer, like you're up all night playing video games?
I do love video games. That's true.
Okay. Now we know
it'll help a lot. Yeah. Of course, I'm not a coding guy. I was lucky to have friends who helped me, especially my friend Freddie Morgenstern, who was very excellent computer scientist, and help us developing, and the platform.
So reading a visual field is almost like reading an X-ray, so getting good at reading X-ray, getting good at reading visual fields. So Dr. Fanelli, I want you to help us with this. Maybe you want to share your screen, because I know you have some images. But so with the visual fields, we start off with the nerve fiber layer, and then we go into the optic nerve, we go into the chiasm, we go into the optic tract, we go into the radiations and the visual cortex, and different defects or problems in the brain that affect this pathway will give different visual fields and help us with our diagnosis. So let's start with the, something that we probably see more, with, maybe a glaucoma patient and the nerve fiber layer. So if we could start with some of those. I know you're sharing your screen right now. So why Dr. Fanelli is sharing his screen, let me just ask Dr. Gonzalez, for a neuro-ophthalmologist who this is their bread and butter, looking at visual fields, how long do you think it takes a neuro-ophthalmologist to get good at being able to read the visual field and knowing where it is in the part of the brain, and doing an MRI or some kind of a scan, and usually being pretty right that is going to be the localization of the defect?
It depends on the purpose, the reason why you did the visual field. If the visual field you did was for screening purposes, it usually takes a few seconds to realize what the problem is, or a few minutes then to go into and make sure that you are looking at the right defect. But if you are then looking at progression, so how the visual field have changed, etc., then it probably takes a little bit longer, because now you want to look into not only the grayscale, but you also want to look into the total impacted deviation to understand whether the defect is due to general homogeneous depress of the hill of vision due to, let's say, refractive errors or cataract, or if it is an actual neurologic disorder. So it doesn't take long most of the time, and the better the technology, the easier will be to accomplish this task. And I wouldn't be surprised if very soon there are actually already exist. There's some program that can detect the kind of defect that you have. I think what we are lacking is the regulatory process to really adopt those kind of automatic assessment of visual field.
And Dr. Fanelli, are you able to share your screen?
Yes, I am. Let me do that here.
Okay.
And there we go. You know, to the point of visual fields being utilized in clinic, everything that we do from a visual field perspective is anatomically guided. Either we're dealing with a known entity, for example, glaucoma, and we do visual fields to monitor how severe the glaucoma is and whether or not we have it stabilized, or vice versa. We're picking up a visual field defect in a screening test, and we need to sort out where in the visual system that problem is. So it all boils down to anatomy. So I just wanted to go through a couple strategies for the docs that are on board listening to this to consider when they're looking at incorporating visual fields. And probably one of the more common indications that we have for visual field testing is in the management of our patients with glaucoma. Now, you know, it brings up the question, well, where is the damage occurring? We have certainly, you know, advanced structural technologies, OCT technologies, to help us see where that damage is occurring in patients with glaucoma. But again, it all boils down to anatomy. This is a multicolor image of a patient who I've seen for years who has advanced glaucoma. Now, this is not a true color picture, but one of the advantages to multimodal imaging is that it can highlight, for example, nerve fiber layer defects, which are hallmark characteristics of glaucoma. So this is a multicolor image here on the left. And then if we're using a green reflectance image, this kind of highlights more anterior retina. And we can see these striations and these arcuate wedge defects that are very common in patients with glaucoma. So we know about glaucoma, where the damage occurs. We have ganglion cell bodies that live here in the center portion of the macula. They give rise to axons, and those axons head in this arcuate fashion toward the optic nerve. Now, we also have a papillomacular bundle of axons that take a straight shot from the center of the fovea over to the optic nerve and are primarily localized in the temporal aspect of the nerve. And we'll get to that when we talk about some of the optic neuropathies. But we can see very clearly here these wedge defects due to loss of axons. So needless to say, when we run a visual field on these individuals, of course, everything is reversed top to bottom in a visual field. Someone with these superior arcuate defects is going to have an inferior arcuate scotoma related to their glaucomatous damage. And then, of course, we're going to repeat those visual fields periodically to make sure that they hopefully remain stable. This is also another patient with advanced glaucoma. Again, a multicolor image, but if we look at the blue reflectance image, we can see a rather large wedge defect here that involves part of the papillomacular bundle, but this is a visual field defect that we would expect to involve fixation. So this patient has a bit more advanced glaucoma. Fixation is involved. We have to be exceedingly careful in stabilizing these patients. We can see inferiorly these arcuate defects down here as well. So this patient has a visual field defect both above and below the horizontal raphe. And I think this highlights very clearly the fact that we have this anatomic horizontal raphe here, where we have visual field defects that are either above or below that horizontal raphe. And when we see visual field defects above or below, typically those visual field defects originate either in the retina itself or the optic nerve. And that helps us to localize some of the visual field defects that we see from a neuro-ophthalmic perspective. And this patient, interestingly, we can see a rather small wedge defect much further away from the optic nerve where we typically see glaucomatous damage. Bottom line, when we're running a visual field, we're testing all of the plots, all of the areas within these particular images, and we'll be able to identify visual field defects that are, for example, here in this wedge defect, but not elsewhere. And that's kind of just a basic overview of what's happening from a glaucoma perspective. Here's the other thing that we need to keep in mind, and this is a schematic showing an arcuate bundle defect here. And when we run a visual field test, you know, there's been a significant number of studies looking at what type of visual field test should we be running on our early glaucoma patients, and then what about for our later, more advanced glaucoma patients. And we were taught years ago to typically run a 24-2 visual field. And one of the downsides to running a 24-2 visual field in an early glaucoma patient, we've all seen these patients. They come in, they may have high pressures, they may have an optic nerve that looks somewhat suspect, and we run a 24-2 standard white on white parametric study, and the visual field comes back relatively clean. There's not a lot to hang our hat on. And that has to deal with the fact that when we're running 24-2 visual fields, we're only testing a small number of target points within the central macula. And in fact, about 50% of the optic nerve axons originate in this central 20 degrees of the macula. So we're really undersampling this central visual field in early glaucoma. And that's why we've moved more toward perhaps utilizing 10-2 visual fields. And I think most of our OCT instruments now are using a variation of the Hood report, which somewhat gives us guidance as to what kind of test points we're going to be testing from a from a functional perspective when we overlay that on top of the structural OCT. Superiorly here we see, or above here we see a 24-2 test points, and we're only going to be able to hit a couple of points in this particular individual where it's going to flag as abnormal. Whereas if we're doing a 10-2 visual field, we may be picking up more points consistent with early glaucoma. So again, it's a relationship between the anatomy that we are given at birth and then the visual field testing points that are overlying that. So we can move on to neuro-op, if you will, but I want to kind of open that.
Yeah, let me answer a couple questions on this if I can. Dr. Gonzalez, at one time there was a 24 or a 30-1, a 30-2, and I think a lot of people don't know what -2 means or -1 means. If you could explain why they picked -2, and no longer is there a 24-1 or a 30-1 or 30-2.
Right. The 1 and 2 protocols are related to the position of the matrix. And basically, at least the last I remember, what happened with number 1 is that some of the locations fell over exactly the raphe that Dr. Fanelli was describing. Yes. And that was a conflict because you never knew whether those points were related to cells responding on the superior or inferior hemiretina. For the reason then is that they sort of like shifted the template in order to avoid the stimulation of the vertical and horizontal lines. And that's basically the differences.
For the midline. Now, why 24-2 versus 30-2? 30-2 many years ago was the test that was done. Now it's more common to the 24-2, and maybe Dr. Fanelli is saying maybe we should be doing, I believe he's saying a 10-2. But why 24-2 is is now in vogue. And what extra advantage would you get out of a 30-2?
Fanelli or
For Dr. Gonzalez.
Oh, okay. It's all about time, basically. The neuro-ophthalmologists usually do 30-2 when they started using the Humphrey visual field test and the octopus. The 24-2 is mostly used for glaucoma specialists. You can say that it's almost the standard of care for glaucoma follow-up. And basically what you do is you avoid those very unreliable peripheral tests. It's not really peripheral, but peripheral tests. And you only, those extreme point, the only one that you use are those related to the expected nasal stat, because we know that it's a very common pattern of defect in patients, or early pattern of defects in patients with glaucoma. So it's all about time, basically, if we want to really down to simplify it.
And Dr. Fanelli, you showed us that the 24-2 may not be good enough for early glaucoma. So because there's not enough points really. So are you saying that 10-2 would be better?
I think studies seem to indicate, and actually a reasonably large study about 18 months ago was published showing that about 50% of patients who have early glaucoma that is seen on structural change fundoscopically and on OCT do not show a visual field defect on a 24-2, but do in fact show a visual field defect on a 10-2 that matches the structural changes. And that is strictly just in the early glaucoma patients. Can you see the pointer that I have on this screen? Okay, and you can see that in this particular example, this test point would be normal, this test point would be normal, this one would probably be borderline. Hard to say, but you're not going to have a lot of points in this 24-2 test point that are going to show up as being defective. Whereas if we put a concentrated number of test points in this central 10 degrees, we're going to be able to pick up more points. So I think there's a move clearly toward using a 10-2 in early glaucoma and using a 24-2 for more advanced glaucoma.
Okay, let's move on to some of the visual field images that you were speaking about.
Well, I have not so much the visual field images, but I did this more from an anatomic perspective on how to approach the neuro-ophthalmic and glaucomatous visual field. So I don't have visual fields per se. I have more along the strategies of what would be going through our mind in choosing a visual field or using a visual field to help localize the problem. Okay. So if that's okay.
Sure, please.
All right. Then let me run through. I've got these, probably the piece of the puzzle that is more challenging for most of us. I mean, we see a lot of glaucoma patients. All of us as optometrists, we see glaucoma patients day in and day out. But one of the ones that, or one of the conditions that tends to cause a little bit more anxiety, and as I alluded to earlier, can be life-threatening, are the neuro-ophthalmic causes of vision loss. And that's a rather complex discussion. And to kind of keep this pretty straightforward, I think that when we look at neuro-ophthalmic causes for vision loss and visual field loss, it's easiest to break this down into three general areas of investigation. Those problems that are pre-chiasmal, those that are chiasmal, and those that are retrochiasmal. And I think that most of the neuro-ophthalmic visual field defects that we're going to see, in fact, all of them are going to fall into one of these three categories.
The All Eyes Visual VRP is a portable vision testing platform that includes visual fields, acuity, color vision testing, pupillometry, and extraocular motility. The visual leverages virtual reality, artificial intelligence, and augmented technologies to enable eye care providers to test for and monitor common eye diseases. Visit alleyes.com for more information.
MacuHealth, your science-born and tested solutions for visual performance, macular degeneration, and dry eye syndrome. New products coming soon. Embrace the science.
Do your patients know what presbyopia is?
There are people who are afraid of the press.
Have you talked to your patients about multifocal contact lenses?
I've heard the bifocal, but not
Right,
multifocal.
exactly, not multifocal.
Do you need help with your multifocal strategy? Learn more at the conclusion of this episode.
And probably the easiest one is prechiasmal visual field loss, because prechiasmal visual field loss is always unilateral. If we're running a visual field on an individual and they have a defect in one eye and not the other, we know anatomically that that problem is somewhere in the globe. Could be the retina, it could be the optic nerve head itself, and it might be behind the globe in the optic nerve, but only up to the chiasm. Now, with most neuro-ophthalmic conditions, there are exceptions to every rule, and this is one of those that does have an exception. And this involves anatomy of certain fibers that decussate and get into the posterior aspect of the contralateral optic nerve. But for the most part, in the large majority of patients, if we see a visual field defect in one eye, one side, and not the other, we know that that is something in the globe or the optic nerve itself. That's as simple as it gets. Now, it becomes a little bit more complex when we get to chiasmal visual field loss, because chiasmal visual field loss is characterized by two things. Number one, it's always going to involve both the right and the left eye visual field. So it's going to be bilateral as opposed to unilateral. It may be symmetric, it may be asymmetric, okay, but it's going to fall into one of two categories, either a bitemporal visual field defect or a binasal visual field defect. And this is where knowing the anatomy helps. We have to understand that the chiasm has some neighbors, and below the chiasm sits the pituitary, above the chiasm sits the third ventricle, lateral to the chiasm are the cavernous sinuses, and inside the cavernous sinuses are the internal carotid arteries. So if we start squashing or obliterating or affecting the medial optic chiasm, we're talking about either a pituitary problem from below or a third ventricle problem from above. Whereas if we're affecting the sides, the lateral aspects of the chiasm, we're going to be either talking about cavernous sinus syndromes or perhaps carotid artery disease. But and again, this particular diagram is something that we're all familiar with. We know that temporal fibers do not decussate at the chiasm, whereas nasal retinal fibers do in fact cross. So if we're affecting the center portion of the optic chiasm, we're going to be affecting nasal retinal fibers, which results in a bitemporal hemianopia. Again, those bitemporal hemianopias may be symmetric, they may not be. Here's an interesting case of an 80-year-old patient who was complaining of visual field loss and having difficulty seeing out of her left eye. She also has glaucoma. So this is an older type of visual field that does show some early glaucomatous damage, but nothing from really a neurologic perspective until we did another visual field a few weeks later. And we begin to see in the left eye a distinct change here and something that almost hugs that vertical meridian. And that's one of the hallmark signs of either a chiasmal or a retrochiasmal field defect, is something that is hugging a visual field defect that is hugging this vertical meridian. And ultimately, this patient, we did a series of visual fields, but ultimately she was found to have a rather large pituitary adenoma that was also involving the cavernous sinus on the left side. Where is her optic chiasm, you ask? It's this little white bar up here that has gotten completely smashed from below. So these visual field defects are very consistent with a pituitary adenoma. Now, post-chiasmal visual field defects are also bilateral, to keep this as simple as possible, and they're going to be either right-sided or left-sided. We call those homonymous, meaning they're the same side. So it's either right homonymous or left homonymous, which the visual field defect, as we know, is on the opposite side of where the problem lies in the retrochiasmal anatomy. So not only can we differentiate, for example, if we have a right homonymous hemianopia, we have a problem in the left side of the brain, we can also differentiate if that is affecting more in the parietal lobe or the temporal lobe, depending upon whether that visual field defect is denser above or below. And we also use the term congruous. Congruous basically means how well those fields can lay on top of each other and be exact carbon copies. So general rule of thumb is that those visual fields that are more congruous are closer to the occipital pole, the occipital tip, whereas those that are less congruous tend to be more anterior, but still retrochiasmal. So again, without getting into too much detail, visual information ends up in the occipital lobe on both the right and left side. So whatever is ending up on the right side of the brain pertains to the left visual field and vice versa. So we're all familiar with the optic radiations. Some of those optic radiations run through the parietal lobe, some run through the temporal lobe, but they ultimately end up in the occipital cortex. And this is kind of what we look at when we're seeing patients in clinic who have a visual field defect. I would suggest to our listeners to verbalize what we're seeing. We're seeing something bilateral here. So we know that this is either chiasmal or retrochiasmal. We can say that this is temporal in nature. In fact, it's bitemporal. So we know that this is a bitemporal visual field defect, which puts us right at the chiasm. And furthermore, this visual field defect is denser above than below, which means that something is impinging the chiasm from below. So in a situation like this, we're certainly going to suspect something from a pituitary perspective. Ancient visual field testing. You mentioned this earlier, Carrie, the Goldman visual field testing. Visual field testing with Goldman perimetry was very good if you had a good tech, but very poor if you didn't have a good tech. So this is an example of a binasal visual field defect, which again is a chiasmal issue affecting both the right and left nasal hemifields. It's rather asymmetric, and this is typical of a cavernous sinus syndrome. And these are the patients that we worry about as well, that come in with complaints. For example, often these folks will say that they have trouble seeing out of their right eye, when it's in fact the right portion of the right and left visual field. So here we have a right homonymous hemianopia that is denser above than below. So we know that this is retrochiasmal. We know that the temporal lobe is involved. We know that the parietal lobe is involved. It's not exactly congruous, so this is in the occipital pole, but this helps us to localize where we need to direct our neuroimaging. Point being that the visual fields are very, very, very descriptive in helping us to locate where the problem is.
So that was a terrific overview. Dr. Gonzalez, anything you want to add to that?
I think they have been an amazing presentation. I guess the only thing that I would say is sometimes it could be a challenge detecting those defects. There's a lot of variation in terms of anatomy, like Dr. Fanelli said, and those variation are the reason why you can have two complete different defects meaning the same, right? Or two same defects meaning totally different things. So you have to be very careful anyway when you are doing this kind of assessment. And so it's very, very, very interesting, very diverse. I think I remember one of the when we were talking about optic neuritis, right? For example, we were talking, paracentral scotoma, the classic scotoma. And one of the things that we learned from the optic neuritis treatment trial is that the optic neuritis can give you any kind of defects. So there's no more classic optic neuritis defects at all, because it can be anything, basically. And that's one of the greater things about this amazing trial.
Dr. Gonzalez, you could see on my screen to the left of the different associated visual field defects. Can you see that?
Yep.
Can you take a look now? If you look at so let's kind of go through that a little bit and add to what Dr. Fanelli said. At the beginning ones are more ones that we may see with glaucoma, but every once in a while we'll see an altitudinal defect. And as you can see, 1D and 1E. When you see something like that, what should the doctors be thinking?
I guess the only advice I would tell, and which is we need to be very careful, is when you are looking, especially an OCT, and not necessarily the same apply for visual field. But when you look into an OCT and you're looking and you're seeing a RNFL defect, we should not think about glaucoma always. We should think about everything, because anything, the list of diseases that can give you a visual field defect, glaucoma-like, it's actually large. It could be ophthalmitis, it could be ischemic optic neuropathy, it could be tumors, it could be trauma, it could be anything, right? So all these kind of defects somehow give us some topographic information, but not necessarily causation or what's the reason why you have a defect. Once you have a topographic information somehow, then you can tune in, right? You can decrease that list, but it still it keeps large. So these are the classic defect. But if we use the example that Dr. Fanelli used, and you look at that one eye that is almost a beautiful hemianopia, and the other eye only have like a very superior, you might miss that if what you have in your head is this kind of diagram. So I would hopefully and thankfully, running an MRI these days are not that difficult, and we can always have that. But this kind of, what I'm trying to say is that this kind of diagrams might mislead the attention if we try just to look at it as the potential or possible visual field defects. Now, if we continue, so the first one, like Dr. Fanelli said very well, most of the defects of the optic nerve are unilateral. It could be, of course, bilateral, but most of the time are unilateral. And but one thing to also keep in mind, especially if you're doing a 24-2, is that you might see a defect unilaterally on the 24-2, but you don't see it on the other eye, not because it doesn't exist, it's because is still very peripheral. And I'm sorry that I'm
Okay.
using the exception, but I think it's probably more important than actually repeat, right, what we are looking here. Now, Fanelli, what do you think about that?
Well, I go to, from my simple mind, I look at, is this a unilateral visual field defect? I know it's in the optic nerve or in the globe. As soon as we start getting into bitemporal or binasal, we're at the chiasm, and everything on one side in both eyes is retrochiasmal. Then you get into the detail, and the devil is always in the detail, and there are always exceptions to every rule. And that the one that you just said is very important, because if we think about it, so we're looking straight ahead with one eye open, we have a much wider visual field off temporally than we do nasally. So we may have a temporal defect that's visible in one side that's just not represented in the other eye, because there's just not enough room to get that visual field. So again, we have to be open-minded that we're not always looking at glaucoma, we're not always looking at optic neuritis, but these visual field tests are one tool, and a very important tool in our toolbox, to help hone in on exactly what the problem is. And Hickham's dictum, patients can bring as many well diseases as they well please to the table. So there's patients who have glaucoma who have pituitary adenomas. There's patients who have ischemic optic neuropathy at age 50 and then develop a hemianopic visual field defects in their 70s because of a stroke in the retrochiasmal. So there's a lot of overlap when you start bringing in multiple disease processes to visual fields. But visual fields are incredibly important. The problem that we've all faced with for years is that patients hate taking visual fields, and doctors, for the most part, hate torturing patients with visual fields, especially in something chronic like glaucoma, where we're seeing this patient 2-3 times a year, and we're almost feel like we're beating them up with the visual field. And virtual fields have just been a game changer in that, because patients, Alberto, as you said, you're bringing the fun back to this. If there ever was fun, I don't know if there ever was fun in a visual field test, but there certainly is fun now. And I'm just coming from clinic earlier today, and I had a patient with his first visual field on the virtual reality headset, your unit, and I asked him, how was it? And he said, I love it. That was actually enjoyable. And I haven't heard patients use the term enjoyable when they're talking about visual fields ever before. So it's a different ball game now, no question.
No, that's why the VR is so amazing. Now, at what point are you going to do imaging when you're looking at this map of these visual field defects, and what kind of imaging are we doing? Dr. Gonzalez.
That's a very good question. There's different approach, of course, depending on the defect that you are looking at. Few principles, right? Remember, most of the visual pathway is packed. All the axons are very packed in the optic nerve, in the chiasm, and the tract, larygeniculus nucleus. Till there, everything is packed. So when you have a defect until the LG end, most of the time, it is a large defect. Of course, it starts, but it's a large defect that affects either the entire eye or the entire hemi field. Once the axons start spreading out, right, and go to parietal and temporal lobes, then the probability to have a complete defect, let's say in a hemifield, it's lower, because now the defect has to be large, or the cause have to be large, either stroke, trauma, or tumors, right? So that's also a kind of principle that we should keep. And when you go down to the last defects, remember that when that pathway start getting confluent again into the occipital lobe, which is the primary visual pathway, because we have different, as I remember, there were 5 visual centers in the brain, but the primary is on the occipital lobe. And also remember that the distributions of the retina in the cortex has a very well-defined distribution, which means that peripheral areas of the retina are more deep in the brain, while the macular area is more superficial, right, in the cortex. And that's why we need to take this into account once you're getting into those lower defects, like for example when you have only a macular hemianopia, or if you have hemianopia with macular spare. Those gives you some kind of like idea of what you are. But I think on this time in 2022, I think the most important, it's especially for us, right? It's fun getting into, oh, the problem is here and here and here, right? But in these times, the imaging technologies are so available. I think the visual field function, it's more like the detection of the problem and then referring the patient to the right specialist. If you have a visual field defect, number one advice is repeat it. Do not run. Repeat the visual field, because remember, the visual field, it's still a psychophysical test, and it might have some variation. And what it looks so obvious in one, it might goes away in the second one. So repeat it, the visual field. That's number one. It's only going to take a few seconds, or a few minutes more, but are worth it. If you repeat the visual field and the defects remains, then you don't want to play with that patient. If you have, of course, you're entitled to do whatever you want, but because you don't know exactly what it is, you always have to think about the worst, and the worst can kill the patient in a few minutes later. So you have to refer the patient to the emergency room as soon as you can. And if there's no dangers to the life, that's okay, perfect. Now we have time, right, to go and look into more details on what it is, what the problem is, etc. But the number one step should be, is the patient's life in danger? That's number one. Because we know some of this, etiologies can really affect the patient's life. So that's number one. So you want to indicate an MRI, you want to indicate an OCT, because now what we thought it was very uncommon, which is the transsynaptic degeneration. Now, with the advent of the OCT, we know that it's more frequent than we thought, and is now unlikely to see strokes post-laryngeal nucleus strokes with ganglion cell defects. It's not uncommon. So that an OCT should be another imaging test that should be used in addition to the MRI. And then if the MRI doesn't come up with anything, then you can try the CT scan, right? Or you can, some depending on the protocol. Some hospital used to do CT scan first, but most of the time, unless you have a solid tumor or tumors of solid tissues like bones, the MRI would always be better.
So Dr. Gonzalez, tell us what the MRI tells us differently than a CT scan.
In In general, the main difference is that the MRI is better for soft tissues imaging, and the CT scan, it's better for like a solid hard tissues like bones. That's the main difference. And if we go more in detail, the CT scan is an X-ray with different protocol, but it's an X-ray stuff, right? That's why bones are better draw in the image. While the MRI basically is looking at what changed when you shift the magnetic field, right, in that patients, and then you use different techniques, right? Depending if it is a functional MRI or if it is just whether you put some dye or not. So there's different techniques, but the main differences are those. The MRIs is mostly uses for soft tissue, which is most of the time what you're looking for. There are tumors that are better to see in CT scan, for example, meningiomas. Meningiomas are, of course, coming from the meninges. Meninges are close to the bones. Sometimes the CT scan it's helpful or provide additional insight of the tumor. But MRI probably is going to be the ones you're going to use the most.
Can I just interject one thought there? And Dr. Gonzalez, you're spot on with that. But one of the challenges that we face clinically, if we're seeing a patient with, for example, a neuro-ophthalmic problem, and we want to get a good look at the soft tissue, an MRI is certainly going to give us a better view than CT imaging. But if we're sending these patients urgently to the emergency department, we need to communicate with the physicians there, because in most emergency rooms, patients that are coming in urgently with vision loss or neurologic complaints, oftentimes will get a CT scan, not because it's quicker and it's cheaper and it's more readily available, but because they're concerned about a cerebral hemorrhage. And three things that CT scans show exceedingly well: bone, air, so sinus disease, and fresh hemorrhages. So if we're worried about or concerned about soft tissue, and we don't articulate that necessarily to the emergency room folks, there's a good likelihood that they're going to get a CT scan, which is going to show lack of a cerebral hemorrhage, hopefully, but it's not going to tell us what the problem is or focus is. And then they're going to have to get scheduled again for the MRI scan. So that happens quite regularly, and it's just an issue of they're concerned about cerebral bleeds, intracranial bleeds.
Dr. Fanelli, that's a great point. Now, if you look at this chart, is there anything on that chart that you may want to point out that maybe you didn't point out from before to the audience?
Well, no, because we can get lost in the details here. And again, if we just look at unilateral defects versus bitemporal, binasal defects, or homonymous defects, we kind of have an idea, at least as to where geographically and anatomically the problem is. What specifically the problem is going to vary depending upon patient demographics, their age, whether there's been any trauma, what other types of neurologic symptoms they may or may not have. So we can spend 6 hours talking about neuro-ophthalmic visual field defects and just get completely lost in that. It's a fascinating topic and we need to know those things, but we lose the forest for the trees sometimes when we do that. But we have to know the trees that are in the forest.
Before we move on, Dr. Gonzalez, is there anything you want to add to the visual field discussion?
I think those general principles, which is what I've been trying to focus first, I think for me is one of the most important, because like Dr. Fanelli said, sometimes get lost on the detail and we forget those major principles. The principle is the visual field is a subjective test. And in consequence, you will whenever you feel something is wrong, repeat it, because there's always time to make a mistake. So just repeat it and make sure that you are confirming what you previously said.
And as you both pointed out, the visual field could mean life or death. So it's a very important test, and it's important that people get screened when they get their eyes examined for a visual field. And I think that's one of the shortcomings when, online refractions, people aren't getting a full scope care. Dr. Fanelli, if you could comment on that.
I think that, the entire COVID thing has brought us to the realization that there is a place, but not a uniform place for virtual visits, especially when it comes to eyes. If it's an external problem, invariably it's a red eye. So a patient's going to take a picture of their red eye and send it to the doc. Well, that narrows it down to about 50 different possibilities, and you really need to see the patient to determine what the basis is of the red eye. But as soon as you start getting into fundus viewing, yes, you can have an OCT run a remote OCT test, and you can screen that to your computer screen. But maybe I'm old school, but I think that we need the ability to be able to look in the eye at the optic nerve, to see depth, to see contours, to see elevation, to see thickness that you're not going to be able to get looking at a two-dimensional screen. So I think there's a time and a place for screening visits, but as far as being able to provide in-depth, full evaluations of patients, especially those with vision loss problems, that they're going to have to be seen face to face. Take a picture's only good as the resolution.
And the eye is very complex. There's a lot of parts to the eye, starting from the lids to the tear film back to the optic nerve, Dr. Gonzalez.
Absolutely.
The All Eyes Visual Hall VRP is a portable vision testing platform that includes visual fields, acuity, color vision testing, pupillometry, and extraocular motility. The visual leverages virtual reality, artificial intelligence, and augmented technologies to enable eye care providers to test for and monitor common eye diseases. Visit alleyes.com for more information.
Your eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with Micromicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and Micromicelle technology.
Fitting multifocal contact lenses presents a big opportunity to meet patient needs while growing your practice. Alcon is your partner not only with our innovative portfolio, but through e-learning. Learn to enhance your multifocal strategy today with the Alcon Experience Academy.
OIE Broadcasting is the emerging leader in social media.
We use scientific entertainment to drive more patients into your office.
Visit oiebroadcasting.com and sign up today.
Each generation was supposed to be healthier than the last one. Lifespan was supposed to be increasing. We were supposed to be in this paradise by now. Instead of getting healthier and healthier, it seems to have gone the opposite way.
Millennials were projected to be the first generation in history to not outlive the generation before them.
We are certainly headed for disaster.
I think a lot of people are beginning to question the whole story.
We live in a time where the paradigms are shifting.
And the optometrist, in my opinion, is one of the best kept secrets.
The public doesn't realize about going to the eye doctor. so many different diseases actually manifest in the eye. The back of the eye is the only place in the body that you could actually see the blood vessels.
Completely non-invasively, you could screen thousands of people, not just for their eye health, but for their whole body health.
Because this disease is here, it's also going to be here.
And I can look into the back of my eyeball, and there are expert doctors on the ground who are looking at my eyeball while I'm doing it.
The eye is the canary of the mind.
The eye is the kingdom.
Will everyone please open their eyes?
Since I bought Safe for You, my dad makes me clean his boat.
Es natural y es un buen producto.
Every time I go back to school, my mom always makes sure that I have my Safe for You products. I bring extra, and my roommates certainly don't mind.
It's a good thing I had Safe for You to clean up after this little guy.
When my hands get dry, I like to wash them with Safe for You.
And most importantly, the reason why I buy Safe for You is because it's safe for me and you.